delighted to introduce Dr. Lara Mitchell, who is a consultant in medicine of the elderly in the QE here in Glasgow. She's the clinical lead for acute medicine of the elderly and also set up and established the Frailty at the Front Door service. Lara is also a Scottish Quality and Safety Fellow, like Gregor and many other clinical leads who have been part of the team. And less than 12 hours ago, Lara was in Marbella. So it has been quite a feat to actually have her here this morning. So we're delighted that she's able to join us and share with us the work on fall. So over to Lara.
Hello, everybody. And I did prioritize this conference. My flight was delayed, so I had a circuitous route to get here. But I'm so delighted to be here and connect with you all face to face. So the title of my talk is, how do we falls-proof Scotland? Start somewhere, start small, but I want to encourage you all, think big. Okay, before we get started, unless you've got any injuries, I don't want you to partake. I'd like you all to stand up. I'd like you to stand on your right leg and just keep standing on your right leg. I'll do it too. While I tell you that there was a study in Japan of over 70s postmenopausal women who stood for 1 minute on one leg, rotated it to the left leg, and back again 3 times. And that study showed that there was increased strength and bone density at the hip. Okay, rotate onto your left leg. So we know that the one leg standing time, if it's less than 10 seconds, you've got an increased risk of vertebral and hip fracture and an increased risk of falls. Okay, you can sit down and relax. Those of you who are a little wobbly, you've got your homework tonight. My 80-year-old father actually will do that when he's doing his teeth. He'll just do one leg each time, 3 times. Okay, over to our aim statement. So you've seen this before. Our aim is to reduce all falls by 20% and falls with harm by 30%. And during this talk, I want to concentrate on the first 2 primary drivers, person-centered care and promoting mobilization. Now, I work at the Queen Elizabeth, which is just over the river, and we have 118 unscheduled care beds. I'm a geriatrician, so we have 16 beds. Latterly, when I've been on call, every single one of those patients has presented with a fall. Now, it may be due to a medical cause, a blood pressure cause. Some of them is due to altered gait and balance and a trip and sustaining injury and needing to come in, but they've all presented with a fall. And I want to start with one of the ladies that I saw very recently when I was on call. She'd had a fall 6 months before. She was just a bit anxious to move. She'd lost her confidence. She was sitting watching television for more parts of the day. She fell overnight. She lay all night and her carer found her the next day. She was more confused. She had a bit of back pain, so she was conveyed to hospital. She went to ED. She waited for a bed for medicine for the elderly. So all that waiting overnight, waiting for the ambulance, waiting in ED, coming into the medicine for the elderly ward, all means muscle mass loss. Sorry, skipped a bit. So diagnosis, she had a fall, she had a delirium, she had a urinary tract infection, she was in urinary retention. She had some back pain, so she had x-rays, and she had a sacral insufficiency fracture and a lumbar vertebral fracture. Spoke to orthopedics, mobilize as able. So she was started on analgesia, and then, yes, within 24 hours, she was confused, she was constipated, she got up, and she fell again in hospital. This is sadly a recurring scenario. So we know that frailty is an increased vulnerability with the inability to withstand stresses. And I love this graph. We've got independence above the dotted line. You or I, if we got a minor illness such as a urinary tract infection, we would dip down, but we would come back up. The older adult will have a varying curve, but sometimes they may not get above that dotted line and stay at reduced independent level. Those frailty syndromes, falls, immobility, delirium, fluctuating disability and incontinence present in a crisis. Oh, sorry, it's jumping around a wee bit. So let's get to the cold, hard facts. I always ask my junior doctors and the medical students, what's the biggest risk factor for a fall? And it's a previous fall. And in fact, the top 5 risk factors for falls are all to do with strength and balance. Strength and balance really matter. Every week in hospital is precious, 10% of muscle mass loss. And this really struck me recently. A hospital admission is the biggest predictor of functional decline. And COVID has exacerbated everything. It's widened the gap in inequalities. It's made our most fragile and vulnerable shielding. And we know from this Public Health England report, which scarily only looked at 3 months of the first lockdown, that the level of inactivity has increased from 27 to 32%, that people are doing a third less strength and balance, so it's reduced from 126 to 77 minutes a week. And if you've got that going on, it's absolutely no surprise that there's increased fall, 3.9 increased fall, with 110,000 older people more likely to have a fall. And they've done some economic evaluation, costing 211 million over 2.5 years. And just remember, that's only 3 months of the first lockdown. So that's startling. So let's talk about deconditioning. So deconditioning is gathering pace as a syndrome. And you know, it wasn't in the literature till 2016. It's physical, psychological, and functional decline due to prolonged bed rest. This is a fantastic article in Age and Aging by Amita Ora very recently. And with the older adult, because of their decreased physiological reserve, there may not be any recovery. I think it's important to say that falls are not a problem of immobility, not a problem of mobility, but of immobility. And I think COVID has made things so much worse for us because we've got intense staff shortages, so that exacerbates things, and we have this risk-averse culture when we don't want people to fall. Oh, sorry, nobody else got it to jump around. So we know from the literature, if people have a fall in hospital, these are the kind of things they're saying to us. They say, when I go out, I'm not sure how to prevent another one. They're more likely to fall at home after a discharge. They've got decreased confidence, they've got post-fall syndrome and anxiety. So, single interventions, we all know, are out. It has to be a multifactorial intervention package. So if we look at the patient, we need to look at mobility and aids. We need to do a medication review. Delirium management comes hand in hand with managing falls in hospital. We need to think about appropriate footwear, and we need to detect and manage orthostatic hypotension. We need to look at things in the environment, such as toileting and continence, minimizing clutter, clear pictorial signage, and think of sensory things, such as vision and glasses and hearing aids. Now, very recently, so I've tagged there the Cochrane review, but very recently there was a meta-analysis, and what came out strongly there was education for patients and staff. And I think that's our challenge, to making sure we educate our staff, but also our patients. And coming into hospital with a fall or having a fall in hospital is a kind of crossroads moment for many people. It's the sliding doors moment. Which way are they going to choose? How are we as health boards going to empower them to make the right choice when they go home? What matters to them? What will make them make the right choice? Sorry. So, you know, we all know it's good to exercise, right? We need to do 150 minutes of moderate exercise a week. But If it was like taking a pill, I would prescribe it twice a day. Would it just be that simple? And we know, that there is often a queue for pills and surgery, and that lifestyle change is more of a challenge, which is why it's so important to think about the barriers to doing this of our older adults. So there is a lot of evidence out there. Sorry, I'm not very good at this, going back and forward. And really they theme it out into 3 areas. So capability, I can't do this, or this isn't hard enough for me. Social, some people love being in a group, but others really hate it. So understanding that about our older adults. Motivation, that's a massive issue. Do our older adults really know the impact if they don't do this? So we all know if we don't brush our teeth twice a day, that our teeth are going to fall out. So what's going to happen if we don't physically move? And obviously there's competing priorities. And then the third group is opportunity. Is the opportunity there for them, and can they access it? However, the good news is that in Scotland, there's a lot of innovation and great ideas and things going on in every single health board. And we put a call out just to ask for visual images about what people are doing in our hospitals. So Scotland is moving. I love the I Can one because I think that empowers the patient and gives them the goals that they're working towards. It also makes it clear to the staff what they can do and their loved ones when they come in. We've got the Paths for All. This is from NHS Tayside. They've set up exercise stations so that when people move around, they're encouraged to do exercises and just getting that little bit of challenge. The active wards, I know in Glasgow, have co-designed with patients areas in Glasgow that patients can walk to. And so they've got that sense of achievement. In NHS Highland, they've adapted Donald, Where's Your Trousers, just to make that connection, to make it more relevant. Get up, get dressed, get moving. We've got all kinds of visuals and movers, and these are all in your delegate bag. So I'd be interested to know who has patient information leaflets, because I think this is the key, and certainly this is the recent evidence base. So I know colleagues in Glasgow are developing a leaflet for patients. It's just in draft format. And we've developed a leaflet for orthostatic hypotension with clear messaging and clear visuals. And again, really happy to share all this work being done across Scotland. So I want to tell you another story about somebody I saw in my syncope clinic. So he's still got medical problems. He's still on medication. And he was in his sort of early 80s, but he looked amazing. And I said to him, what's your secret? He said, I refuse to grow old. I can take a pill or I can move. And this is what he said to me. Start somewhere, start small. I think Professor Leach said that as well. I'm not sure if my patient told me that before the patient did. So just a little bit of something all the time. And these were the key things that he said to me. And one of my designer friends made it into this lovely visual. Because I think a lot of the time, exercise is a chore. But he said, make it fun. Tap into what your patients love. What do they want to do? What's that dance class? What do they enjoy doing? Make it outside. Make it with others. Make it routine. And make it easy. Now, I hope you don't mind, but I just want to take you out of Scotland for 2 minutes to the blue zones. Hands up who's heard of the blue zones. Okay, not a lot of people. Great, okay. So it's 5 areas across the world where people live the longest. So they have the highest population density of those people over 100. Now, what's really important also about that is they live the longest without comorbidity. So there's a place in California, there's a place in Costa Rica, in Italy, in Greece, in Japan. What they have in common is they're next to hills and sea, but they have different cultures. And people have been there to study what's going on, what do they do that we're not doing. So this was the key thing, move naturally. We're not saying go to the gym and pump iron and do all these things. Move naturally. It's part of their lives. It's part of their culture to move, to garden, to walk, to housework, to connect with others. They also have a purpose, so they know why they wake up. And do you know what? Having a purpose gives you an extra 7 years in your life expectancy. So they have that sense of community. So I'm thinking of buying a house in Costa Rica because then I can make it to 100. And they don't eat deep fried Mars bars. I'm not aware they're on sale at any of these blue zones. They eat till they're 80% full up, and they eat mostly plant-based diet. So what we're talking about unscheduled care, acute, but what's going on in the community is the litmus test to what's going on in our hospitals. So I just want to tell you very quickly about Oban. And I'm wondering, is it the next blue zone? So they have a medical center there. They have frailty identification and stratification. They have a weekly clinic. They have MDT and role blurring, and they do a comprehensive geriatric assessment. They have a therapist assessment, referral to physical trainer. They have meaningful goals established, so they understand what makes it special for that person, and a tailored program of exercise. And this is what they've found. They've found an average reduction from high falls risk to low. They've increased housebound to active. They've increased gym membership, and they've reduced social isolation. And this is what really staggered me. So they've stratified their frailty, and what they've done is that in the moderate frailty group, they've moved 80% up to mild frailty. And I just found that staggering. Now, they weren't funded to work out. They weren't funded to work out whether this was effective or not. So they've just got data till 2018. But there was a line of the falls reducing. Okay, so I'm going to bring it back to PJ paralysis. You've all heard of PJ paralysis. Get up, get dressed, get moving. Now, this is a global movement now. And do you know when this started? Was 2018. And it started in the Australian outback. I'm not going to do an Aussie accent, but there was a patient there who was rehabbing, and he had his pajamas on, and he said, do you know what? I really feel like a barbecue. And the nurses were saying, can't have a barbecue in your pajamas. So they got him dressed, and hopefully he went home shortly after that. But that's how that movement started. And Brian Dolan is the man behind this big idea, this movement, and also the last 1,000 days. And I asked him if he would record for us a 5-minute video, a message for Scotland. So I think we're just going to play it now.
Hello, my name is Brian Dolan, and I'm the originator of the End PJ Paralysis and Last 1,000 Days campaigns. And when it comes to the latter, I think that can be articulated in the question, if you had 1,000 days left to live, how many would you choose to spend in hospital? I'm going to think about the incredible work of David Clark et al. From 2014, where they looked at 25 hospitals, 10,000 patients across Scotland over a year. And they found that 48% of people over the age of 85 will die within 1 year of a hospital admission. It raises the issue of how do we enable people to get home to be with their loved ones for as much time as they can. I think we talk a lot about reducing length of stay instead of giving patients back time. We talk about days in hospital, and maybe we could reframe it as looking at days away from home, because that would help us reframe how we think, what we think about patients' time. And one of the things it does happens to people when they're in hospital is they get into gowns, they get into pajamas, they're then paralyzed in their pajamas till the day they leave, and which is why we have the campaign End PJ Paralysis. Because enabling people to get up, get dressed, get moving, it keeps them safer. We know it reduces falls. And I'm troubled by the thought that 1 in 25, 4% of people who have a fractured neck or femur, it occurs as a consequence, or rather an indirect result, of being in hospital, and in practice, probably as a consequence of deconditioning. And I really passionately believe we could halve that number if we encourage people to mobilize and get dressed. And even the language of falls prevention, it strikes me as a deficit, a based approach, a deficit thinking approach. And instead of falls prevention, maybe we should be thinking in terms of safer mobility, because the language does shape experience. The language does shape how we think about what we do. And the fantastic work and working with Lara is just it's a precious thing. Her way of thinking, her desire to reduce falls, which is something we all want. It's not one of us, it's all of us. But I think what it also means is, do we need to rethink what we think? Because 21st century literacy, as organizational psychologist Grant Adams thinks of it, is it's not about whether we can write or read. It will be whether we can learn, unlearn, and relearn. And if COVID has taught us anything, it taught us about challenging the orthodoxies, the things we said that couldn't be done, the things that would take too long. Suddenly they occurred, as if it feels like there's a case for a COVID guardian to protect all of the extraordinary gains that we made, and making sure that we keep those, because I fear sometimes we slide back into the old ways of doing and the old ways of thinking. And having been in Liverpool last week and in Worcester, in fact, it was in Salford University where I'm an honorary professor of leadership in healthcare yesterday, as I speak this, it struck me that we have this urgent need to really think again about how we can prevent falls, because deconditioning has spread past the hospital into home settings as an unintended consequence of the world's largest social experiment, which was shielding. So we have work to do. We have more work to do. Our work, in many ways, it is endless, but it's always about trying to make it better. Because if we're really lucky, we're all older people in training. And we will wake up one day in a time that will come terrifyingly quickly, where instead of being the people delivering care, we're the ones giving care and receiving care and getting it from other people. So we have a vested interest in this. We have a vested interest in creating health systems that value people's time, that keep them mobilizing and maintaining their dignity, their humanity, their agency, their sense of self. All of these things matter, because one day they will matter to us even more, because they will be us. And I'm always struck that when I look at the stuff that has done in Scotland in terms of 10,000 fewer trauma-related deaths, the kind of public health work that Scotland has led in, it really strikes me, if there's any country that can do this, and I speak as a fellow Celt, is there any place that can do it, it'll be in Scotland. So take care. Thank you for what you do, and I'm proud to be a small part of a big journey.
Framing of language about falls prevention being safe mobilization, and actually the scary thought that we're all older adults in training. So maybe you'll all go doing single leg balance when you do your teeth tonight. So what is our call to action? My call to action is bring it back to the patient. Let's always bring it back to the patient. Start somewhere, start small, but think big. And there's a lot of amazing innovation going on in Scotland. So let's connect. Let's make that happen. Find friends and collaborate, and let's allow our team members to innovate and make change. Measure something, and in everything that we do, understand the patient, their purpose, and inspire them to move. And that's me done. Thank you.
Thank you so much, Lara. I mean, really thinking there about that change in mindset, change in thinking, change in practice, and really that refocus on what we can do. And I'm also struck about we are an older person in training. Blimey, that's a thought that's not going to leave my head now. Let's move to some quick questions. Is there anything from our virtual delegates?
Thanks very much, Lara. Again, that was another fantastic presentation. You are off the hook in terms of questions, but there are a couple of really good comments that I just thought I'd share with you. So Claire Baxter from NHS Lothian has said, it's important to have meaningful and purposeful movement, which is individualised and linked with people's interests. This will help sustain movement. And Una McFadden has commented, please include the young frail in these initiatives as they too can benefit, but are often excluded from age-related projects.
Really important.
So a couple of comments there.
This should be across, this whole thing is all, we should all be starting now. But any change that you make now will affect you later on in life. And I think that first comment is absolutely key. That's what I picked up from speaking to the Oban team, is it was that personalised approach to care. And understanding where the patient was at and what their purpose was. And also importantly, the third sector involvement there was quite incredible. The healthy options third sector involvement was key.
Any questions in the room?
Thank you so much. That was really interesting presentation. My name is Yazid Kashwa, and I'm an assistant lecturer of physiotherapy in Queen Margaret University. So one of the many really important points that you raised is to motivate the patients, because if we spend as much time trying to recognize the most important parameters of an exercise or an active lifestyle, still a barrier that still exists is to motivate our patients and to inspire them to move. So I think with regard to this, not biomedical skill, but more psychosocial skills, are there any resources that you'd recommend to inform us as practitioners, whether physios or any members of the MDT who work clinically with the patients, as to how to run this effective motivational interviewing? Thank you so much. I mean, any resources online to guide us through that? Thanks so much again.
Can I just clarify what the question was? Oh,
I mean,
any resources to specify?
Yeah, how to motivate our patients psychologically, yeah.
Okay, so I think that is about getting your team together and working together, because it's not just one person. I think we've all got, so anytime I speak to somebody, I'm always understanding where they're going, but I'm just one person with one patient. So it's just inspiring the whole team just to ask those questions. Now, Dawn Skelton's got 3 questions that you can ask, and there's a 5-minute one and a 10-minute one, and I'll get the resource to you. I'll have a chat with Jo Marie, because that's a package of how to ask the questions, and that might facilitate those conversations. I actually can't remember the name of it right now, but we will get it. Have you got that?
Please.
Yes, it is.
Thank you. I'm going to leave it there, because we are now, I'm standing between you and your lunch. And I look forward to you all having a fantastic afternoon this afternoon, and we'll see you later. Thank you.